Good afternoon, everyone. Thanks, Amit, for setting the stage and involving me in this consensus group. I think quite a few important points have been highlighted already very nicely. Dr. Urman Dhruv highlighted the intricacies related with the number of aging rather than the concept of aging, and then Sandeep highlighted very nicely the various points that need to be considered. So what I'm going to do is very briefly take you through what is the current scenario. If you look at the global prevalence of diabetes, we know that it increases with aging, and we have a significant number of people living with diabetes above the age of 65, and especially if you look at the numbers above the age of 70 and to 75 also. And if you look at the prevalence, the highest prevalence is seen in the group which is above 75, 65 to 75, 70 years of age. Almost 1 in 4 to 1 in 5 people in that age group are living with diabetes. Also, and this affects both men and women, and also it is responsible for the higher mortality in this age group. The diabetes related mortality also increases with age, so we have to be very careful when we are dealing with this age group. Second thing is, now with change in the scenario, global scenario, we are seeing more and more obesity and insulin resistance along with aging. So we always thought that diabetes related to aging was more to do with insulin resistance that comes with aging because of the loss of muscle mass and increase in insulin resistance. But now we are seeing more of obesity also as one of the components which is there in people in this group. And we have already seen these slides from Sandeep that ADA standard of care has proposed the 4M for care, and it recommends in general that we need to assess medical, psychosocial, functional and social domains of older adults with diabetes to provide a framework to determine goals and therapeutic approaches. And we need to screen at least annually for the geriatric syndromes like cognitive impairment, depression, urinary incontinence, falls, persistent pain, and also importantly hypoglycemia. Then there is a challenge of polypharmacy in elderly population and may affect diabetes management. Then there are certain differences if you look at the younger and elderly population. The people who are in the elderly group and have diabetes are more likely to have comorbid hypertension and nephropathy or neuropathy or peripheral arterial disease. Surprisingly, these people have lesser prevalence of retinopathy. And if you look at now the phenotypes that are being considered, the heterogeneity of diabetes profiles, so mild age-related diabetes is one of the common or more prevalent types of diabetes and affects the elderly. Now, important thing is in this age group or the phenotype of MARD, we have people who get diabetes in the elderly age group, they have lower levels of A1C. They don't get very high A1Cs usually. Their BMIs are also not very high generally, but we are seeing a shift towards high BMIs now. Their HOMA score, if you look at the insulin resistance, is there, but again not very high, and sensitivity is definitely compromised. And ADA has already suggested that we should use the 4M framework, looking at mentation, medications, mobility, and what matters most. And if you look at the what matters most has some of very key points which are important in managing people with diabetes. We have to look at the goals that we need to achieve and what are the expectations from the individual who's getting treated. Symptoms, disease burden, meal and treatment preferences. Person wants to stay off injectables, we have to respect that because we don't need to give a goal of less than 7%. The risk and benefit ratio of the treatment. The other issues relating to loneliness, social isolation, and also we have to keep in mind the life expectancy. Somebody at the age of 75 doesn't need to be treated aggressively to prevent complications for next 20 years. Because if somebody is getting diabetes at 70, it is unlikely that person is going to get any complication less than 85 years of age. Otherwise also, so killing quality of life is, not important. Uh, it is not advisable. So, comprehensive diabetes management in elderly integrates key steps to address unique challenges of aging population. One is the first thing is the identification of the key challenges what are there. Then what are the advances in drugs that are available now which are more specific for this age group and which have been shown to be beneficial in the elderly group. Then we have to look for the personalized interventions. We can also adopt digital technologies and AI driven solutions to support the care and make quality of life better. So some of the key unmet needs that I have been able to pick up is, one, diabetes in elderly is not identified as a separate entity, which it should be. We treat them with type 2 diabetes as we treat them with diabetes in younger population. No two elderly are same, and they are not similar to younger people with diabetes. I showed you differences in the younger and elderly population also. So approach to diabetes needs to be personalized in elderly population. That is very clear. We have to keep in mind biology, that is the differences in the mechanisms which are contributing to hyperglycemia, and also the biological factors which are prevalent in elderly group which are not in younger group, like frailty, like sarcopenia, like osteoporosis, like osteoarthritis. So many factors are there which are going to influence the treatment strategies. Then we have to look at mentation. Can the person take care of his own medication and lifestyle, or needs to be supported? Then we have to look at the physical limitations. Not only physical limitations in terms of mobility, in terms of sight, in terms of hearing. You are giving them, somebody is asking for a teleconsultation at the age of 75 years, you are telling something on phone, person may be getting totally wrong. So you have to keep all these things in mind when you are using even technology to support management of diabetes in elderly group. And then social factors are very important: accessibility, affordability, social factors, in society, societal support, where they are living, the living habitat provide support for their management or no. What is the family support? What is cultural background? What are the financial factors? Can they support all the treatment, or they are financially insecure, so they don't want to take treatment also? Then loneliness is one of the important things that is coming up, as Urman Bhai also highlighted. So these are some of the key unmet needs that we have to focus on when we are going for drafting a consensus, for management of diabetes in elderly in Indian setting. With that, I conclude. Thank you. I think I finished very much in time.